This video is about medial medullary syndrome. Now, one thing that's important to understand before jumping on to medial medullary syndrome is how do we differentiate between a lesion in the medulla or a lesion in the pons or a lesion in the midbrain. The one most important thing that I do when I am trying to differentiate between the three different regions of lesion is I try to find out where the cranial nerves are originating. So we know that when we're talking about the midbrain, the cranial nerves that are involved are 3 and 4. When we're talking about the pons, we're talking about cranial nerves 5, 6, 7, and 8. And when we're talking about the medulla, we are talking about 9, 10, 11, 12. Now there are some exceptions, and it can be a little complicated than just the way I said it, but those scenarios are not the common one that is commonly tested on the board, especially for step 1. So let's just organize our thought in that way, that the easiest way to differentiate between a lesion in the medulla or pons or midbrain is through the clue with the cranial nerve that is originating from that region. So let me give you a quick example. So let's say if they have a patient with oculomotor nerve palsy along with other symptoms of a lesion of the brainstem, we can instantly jump to the conclusion that the problem or the lesion is in the midbrain, because oculomotor nerve or oculomotor nucleus originates in the midbrain. Or let's say if they're talking about the hypoglossal nerve, which supplies the tongue, the muscles of the tongue, then we can say, oh, well, that must be the medulla, because the hypoglossal nerve is in the medulla. So just like that. But it's, like I said, it's not as simple as it sounds. They could be particularly talking about a hypoglossal nerve problem. So we have to be aware that only when we're talking about lesions of the brainstem, the easiest way to differentiate is through the cranial nerves. So that's one thing. Okay, so now let's talk about medial medullary syndrome. So in medial medullary syndrome, if you think about what are the tracts that's present in the medial medulla, you will see that there's the corticospinal tract, the medial lemniscus, and the hypoglossal nerve root. Those are the three things that is present in the medial medulla of the brainstem. And be aware that this is above the pyramidal decussation, okay? The pyramidal decussation has not taken place when we're talking about lesion in the midbrain. As a result, what happens is corticospinal tract, let's say corticospinal tract is coming down the left side and the lesion is in the medulla. You can automatically assume that the effect is going to be on the right side. Why? That's because after it comes down to the medulla, in the pyramids, the corticospinal tract decussates to come down onto the right side. It crosses onto the contralateral side. So that's why I wrote down corticospinal tract, the effect is going to be contralateral. Next thing is the dorsal column or the medial lemniscus. So this is a tract which is coming from the skin or from the body onto the brain. Okay, it's moving up. The first order neurons makes its synapse at the nucleus gracilis and cuneatus, and then it makes a synapse, and the synapse makes it move along to the other side. So for example, if we sense vibration on the right side, vibration proprioception on the right side, the nerve will carry the impulse from our body onto the spinal cord on the right side. And then the first order neuron is going to make a synapse and move onto the left side. And then it's going to go up onto the thalamus and then onto the brain. Now, the fact that it moves onto the contralateral side once it's up in the brain is another way of determining that the effect is going to be on the contralateral side. So it's very important to understand that medial lemniscus effect, if the lesion is in the midbrain, if the lesion is in the brainstem, the effect we're going to see is going to be on the contralateral side, because the medial lemniscus, once it becomes medial lemniscus, it is crossed onto the contralateral side. And the last but not the least is the hypoglossal nerve root. So for hypoglossal nerve root, see, that's cranial nerve 12, and like I mentioned, cranial nerve 12 is originating in the medulla, and it's originating before the pyramidal decussation. But even then, the hypoglossal nerve stays ipsilateral. So this is, if you have a scenario where they talk about the hypoglossal nerve root problem, if they talk about medial lemniscus problem, they talk about corticospinal tract problem, okay, and you're sitting down and thinking, where is this problem? Oh, I know, this is in the medulla. Why? That's because the hypoglossal nerve root is there. The cranial nerve 12 originates in the medulla. That's why. So now, the only thing that I have to differentiate is from the medial medullary syndrome from the lateral medullary syndrome. And if you look at a picture of medial medullary syndrome, you will clearly see that in the medial side, the two tracts that we have to worry about is corticospinal tract and medial lemniscus, and that's it. And the interesting thing is that this two tracts stays the same way even in the pons. So when we go to the pons, we will see the exact same thing. So let's quickly summarize what we have learned. We have learned that the cranial nerves 3 and 4 is coming from the midbrain, 5, 6, 7, and 8 is coming from the pons, and 9, 10, 11, 12 is coming from the medulla. Okay, now the medial medulla is supplied by the anterior spinal artery. The lateral medulla is supplied by PICA, or posterior inferior cerebellar artery. If there is a block in the anterior spinal artery, then we're going to have medial medullary syndrome. If there is a block in the PICA, then we're going to have lateral medullary syndrome. The three things that we have to worry about, or the three check marks we need to get when we're checking for medial medullary syndrome is there corticospinal tract deficits, if there's medial lemniscus deficit, and if there's hypoglossal nerve deficit. Again, the way we differentiate primarily from medial medullary syndrome from lateral medullary syndrome is by the fact that medial medulla is going to have hypoglossal and lateral medulla is not going to have hypoglossal nerve root. So that's about it. That's medial medullary syndrome.